Is Giovanni Casella here? Yeah? Okay. So we will start for the second debate because we are waiting Professor Sylvia Weiner.
Okay. So good afternoon, everyone, and welcome to the recurrent weight gain after sleep debate session for this afternoon. I'm Lillian Cow, and I'm chairing this, and we have Professor Almino Ramos and Professor Luigi Piazza, when he gets here, moderating this session for us. So the pattern today is what we'll do is we'll have 3 debates, 4 against, a rebuttal, and then the moderator will make a comment. Why I chose recurrent weight gain after sleeve for this session? As you know, sleeve gastrectomy is the most common operation performed around the world. Our recent IFSO 2023 global registry showed that sleeve gastrectomy comprised 65% of the world procedures. So it's still a very common procedure. It is 20 years since its inception, and we are still doing sleeve gastrectomies as the most common procedure. So I thought it would be very interesting to debate various aspects of the sleeve. And so we'll start off this afternoon with the second debate, which is recurrent weight gain after sleeve gastrectomy, is it the patient's fault? So I'll invite Dr. Giovanni Casella for this topic.
Good afternoon. Thank you, Mr. Chair, for your kindly presentation. Thank you to the scientific...
Just a moment, because we have the first presentation. We are starting with the second debate, please. Giovanna Casella.
Casella. And thank you to President Professor Angrisani for the invitation. Okay, that's all right. Thank you. So I am for, it is the patient's fault. No disclosure. This is my case, mixed disclosure. And the question is it the patient's fault? And the answer is quite easy. This is a typical beach lunch in desert island. And this is a typical beach lunch in South Italy. So, of course, to answer, we have to explore more aspects. And I would like to start by our study, published in 2018. We analyzed 140 patients with a long-term follow-up, 10 years follow-up. And when we compare the 2 groups of patients with on blue with stable weight and patient on orange with the weight regain, you can see as in the first 2 years the operation work in all patients, and the line are superimposable. But from the second year, something goes wrong, but only for some patients. So this is the first observation. The procedure work. And so when we look at the question, maybe we have to investigate on the what is mean patient fault. If we mean everything that is different from the surgical technique, we have to consider not only behavior, but only other aspects like as genetics and social circumstances. You can see as genetics proved to play a fundamental role in the etiology of obesity. In this study were analyzed monozygotic and dizygotic twins. You can see as monozygotic are identical in terms of overweight, while dizygotic that live in the same home and eat at the same table are different. And at the end of the century, Maes concluded that genetic factors account for 20 to 60% of variation in BMI. And the weight, so, is genetically determined. And after the weight loss induced by sleeve gastrectomy, neuroendocrine mechanisms are activated to restore the initial weight. As Busetto described well in his study. And for sure, this is genetic is the patient fault, it's not a surgeon fault. Then, when we look at the behavior, you can see this paper. The title is Lifestyle Modification Parallels to Sleeve Success. And 114 patients are analyzed with a 5-year follow-up. And Barros and food tolerance score were assessed. And when the authors try to understand the lifestyle modification score, they ask to the patient if they changed significantly the lifestyle. So the answers on blue is yes at the first year after the operation in 80% of patients, but 5 years post-operative, the yes answer is less than 20%. So the authors conclude that weight regain was mainly attributed to bad nutrition habits, lack of exercise in the later years after the procedure. This is an interesting study by Lauti, and she studied 38 patients submitted to sleeve gastrectomy with weight regain. And she studied this patient with focus group discussions in order to evaluate the opinion of the patient about the reason of the weight regain. And the patient took responsibility of their own behavior as most important factor to maintain the weight loss. The authors identify the most important factor which influenced the behaviors of good eating and exercise pattern as psychological factors, health factors, financial burden, and available support. I would like to underline the cost, because this is the real life of our patients. The sentence, it's so much easier to eat carbs than protein, it's cheaper. This is what happened to our patient. Then, more about behavior. This is a study with the 100 laparoscopic sleeve gastrectomy, and the authors compare the patients with weight regain and patient with stable weight. You can see as in the first group, you can say yes, in the first group, uncontrolled eating and emotional eating are significantly higher in the first group compared to patient with stable weight. So behavior have a dramatic importance in the weight outcome. And maladaptive eating behavior can appear after sleeve gastrectomy, especially in those subjects who develop GERD symptoms or dysphagia, that are very frequent symptoms in a patient submitted to sleeve gastrectomy. for example, for mid-gastric stenosis or migration of the tube into the mediastinum. And this group of patients try to compensate these disturbing symptoms by nibbling carb-rich food, such as crackers or snacks or smoothies. The last aspect that I would like to underline is social circumstances. The social circumstances can deeply affect weight outcomes. Expectations not always are in line with the reality. You can see here the lines. Different events occurring during the patient's life can lead back to bad eating habits. For example, marriage, pregnancies, divorce, grief. Our patients are young, most are females. And you can see on a recent and very interesting study published on Annals of Surgery. You can see there our patients have an high possibility to change his marital status at 2 years and 5 years after the operation. So there is a risk of marriage. I don't know if there is a risk, the marriage, maybe. In 18% separation, in 16% at 5 years, which is the correlation with the weight. You can see here in a Singapore study in 2000, published on 2022 on 270 sleeve gastrectomy, patients with higher level of marriage satisfaction showed significantly more prolonged maintenance of weight loss compared with patients who reported lower marital satisfaction. Then pregnancy. You can see here in 119 female undergone laparoscopic sleeve gastrectomy that experienced pregnancies. The weight loss from the operation until conception was similar, but gestational weight gain is insufficient in 26%, appropriate in 23%, but excessive in half of patients. Yes, 30 seconds. So, sometimes the three aspects can be found together. In this work, there is an association between parental weight status and weight loss outcome in patients after sleeve gastrectomy. So the patient weight loss was significantly lower when both parents had obesity. So this is the patient's family fault. So in conclusion, weight regain after sleeve gastrectomy for sure is multifactorial, but the most factors are related to the patient. Genetic, behavioral, environmental aspects should be considered. And I would like to conclude with our patient 8 years after sleeve gastrectomy that crossed the line after marathon. He didn't had a weight regain. So it's a patient fault. Thank you.
Thank you, Giovanni. You may sit up here if you like. You have a rebuttal, so you can sit up here. I'd like to invite Dr. Asim Shabir from Singapore to talk about against the patient's fault.
Very good evening. Thank you very much for the honor of the podium. Can I have my slides? Thank you, Giovanni. You were a great competitor. Thank you, true gentleman, as I might say. While my slides come up, just a question to your genetics thing, quite answer. I wish I was a designer baby. I wish my parents chose who I would be. Unfortunately, the truth is that's not the case in today's world. Till that day, genetics will be put aside. I have no potential conflict of interest. That's my case mix. Let's go to the basics and fundamentals. Let's play by the book. Obesity is a disease. a disease that's governed by many alterations in body function, characterized by symptoms and associated with harm. If we call it a disease, then how can it be a patient's fault? Did I induce it? Giovanni said genetics. I wish I was a designer baby. I am not. What is obesity? Is it just a disease? It's a chronic relapsing disease. It's going to come back again and again. No matter what I do, how I treat, I need medicines, I need surgery, I need to continue to go on to it. How can it be my fault if I don't and if I regain weight? Which theory do you believe in obesity? Do you believe in the three-bear theory? Do you believe in the Pika theory? Do you believe in the set point theory? Whichever theory you believe in, how is it the patient's fault? Now, here, Giovanni said, yes, I agree, there's social impacts, there's genetics. Of all these complex physiological interactions that we have learned over time, which of these does surgery correct at one go? Maybe hardly two aspects of it, maybe the third aspect of it. What about the rest of the 9? Surgery does not address them. Have we ever gone to a patient and put them to sleep? Have we looked at their emotional outcomes? Have we gone to shop with them to see whether they can afford the kind of food that we prescribe to them? The answer is no. We only treat a portion of the patient's difficulties, not the patient itself. Aren't we taught weight fluctuates with time? Even in a day, our weight fluctuates. What's the big deal about it? Was it always about just losing the weight? It was never a problem. It was always a problem to keep that weight off. That's normal physiology. Welcome to the real world. It was never about keeping it off. Here it is. What's the difference? Patients lose weight, they go down, but they ultimately gain weight to come back to whichever theory you belong to. In sleep, yeah, it changes a few mechanisms we've discussed. What about the other factors? What about the mental health? I'm born to a family which is psychologically impaired. Is that my fault? I'm born into an environment where people have an obesogenic diet. Is that my fault? What have we changed around the patients? I am on medications that prone me to becoming obese as a patient. Is that my fault? The answer is no. You can't blame the pit. Now let's come to ourselves as a community insurgents. We are in 2021 publishing a book on standardizing a technique which is called sleeve gastrectomy, which we have debated over 1.5 decades about, and yet we do not have agreement as to what it is. And we are still doing modified Delphi question, and we tell the patient it's your fault when you fail a procedure? Come on, guys, we must be honest. What as surgical community have we done? Now let's look at that. How many of us are advocates of doing body contouring after bariatric surgery or educate our patients? None of us, hardly any of us. Here is clear data to show that if you advise patients to have body contouring, they are less likely to gain weight. How many of our patients have that advice? None of us, come on. All right, this is the 4th IFSO Global Registry report. And I put this report just to show you how good we are in our dealings with our patients and how well they follow up with us. Meager, everybody in this hall understands that at 2 years, if you have 40% follow-up, you have done a wow job. What about the rest of the 60% that are not following up? Are those in my data point? All the reports that I'm getting out, are those patients there? Did they all do well or they didn't do well? We are interpreting data based on what we know. What about the 60% we don't even know about? Where do they fall? So is data really correct? I challenge you. Right? I understand, Giovanni rightly put out. Yeah, patients live in the dream world. I want to have my French fries. I want to have my burgers, my pizzas. I want to get spoiled in this world of fast food. But did the people around me make that change for me? How could it be my fault? I live a sedentary life. Partly my fault. I give it to Giovanni, yes, as a patient. That could be my fault. I'm inflicted with disease, a disease that's surrounded and works around obesity as a patient. And I'm given medications. And the medical community tells me I do not have a better drug for you than this. Unfortunately, one of the side effects of this drug is you're going to get obese. Is that my fault? I don't think so. We've done a great procedure, a sleeve. Even today, the whole day we are debating about a single complication, reflux disease. I drink high-calorie liquids and other stuff so that I can extinguish the fire within me that's burning because the medical fraternity failed to deliver what it was supposed to deliver without a side effect. As a patient, is that my fault? Well, let's go. The answer is generally no. The verdict is innocent until proven guilty. Is it my fault? The answer is no. I'll give Giovanni more time. I think the time is to support the patients in their journey, to come together, to understand the patient's perspective and not blame the patient for what has gone wrong. Thank you very much.
Thank you, Asim. Giovanni, do you have a rebuttal?
No rebuttal. I think the two presentations go in the same way, I think. And the important is to do not create a stigma on the patient. This is the most important, I think. To improve the care after the operation, to improve the follow-up, is a challenge for our health system, for us, multidisciplinary team. I think this is the most important improvement for our patient.
Okay, Almino, what do you think?
That's very interesting because I have my personal idea about this topic, but looking for both presentations here from Professor Giovanni and Professor Asim, I think that I change a little my way of thinking, and right now I would say that regarding this question, maybe 30% can be related to the patient and 70% can be related to the disease. But I think that the major component here is the normal evolution of a chronic and relapsing disease over time. And if we are looking in a way to put the fault of the patient, I think that we can also think about how much is the fault of the surgeon. Did I recommend a good surgery for this patient? There is a fail, and this fail is related to the patient, to the disease, or because I should recommend for this patient a duodenal switch, a SADIS, or a gastric bypass, and not a sleeve gastrectomy. So I think that is right now, this is very complex. It's difficult to have an answer that will serve to explain all the cases, and we have to take this patient by patient.
I think we've got time for a comment or a question.
Yes, it's Luigi. Just, I couldn't agree more with Almino, but I want to clarify that this is after you can blame the patient, after you know where is your anatomy. Because if, I think Sabir was mentioning that after so many years we are still discussing which is the best sleeve gastrectomy to talk of the most common operation. And the problem is that it's the patient's fault if you know that the operation was done properly. Because if this is the assumption, is all the argument you are saying, Almino, are right. But if you have somebody that does not have a 90% gastric volume reduction, for the example of sleeve, and has what I call the mini sleeve, the 30% reduction, or what I call the mid sleeve, the 50% volume reduction, I think it's not the patient's fault if he regain weight. So I think this is very important, and this is into the direction where you are working, because I have colleagues of mine that are doing 1,000 operations, and people tell me they do sleeve gastrectomy in 10 minutes. Fantastic. I can't, absolutely. So it depends how much importance are we giving to our surgical manufacture.
Exactly, Luigi. I agree in this point. But I think that right now we have some prognostic factors very clear related to sleeve gastrectomy. So when we recommend a sleeve gastrectomy for a patient with BMI over 50, the chance of fail over time is huge, because we are recommending a surgery in a situation that right now we know that the result over time will not be good, and the same for diabetic patient or the patients
unless
with
you
reflux.
are not doing as a second stage operation.
Okay, well, thank you for our first debate. That was interesting. And thank you very much, Asim and Giovanni, for starting the debate for us.
So in the end of the story, Lilian, is patient fault or not?
I'll let the audience decide themselves.
Yeah.
Now, do we have Silver Weiner here? Do we have David Sauer here? David is here? Yes?
Yes, you.
All right, then we'll go to the third debate. So the third debate is recurrent weight gain after sleeve gastrectomy. 4 is conversion or revisional surgery the answer? And I'm going to invite Dr. Jacob Chisholm from Australia to debate this. Thank you, Jacob.
Thank you, Dr. Cow, and thank you, Dr. Angrisani, for inviting me to take part in this debate. It's a real honour to be here. That's the title of my talk. That's what I was. It's not in your book, but it was in my original email. Weight recidivism after sleeve gastrectomy 4 revisional surgery is the answer. So I have no potential conflict of interest. That's my case mix disclosure. Revisional maybe 20% and probably increasing. So when I used to do debates at school, we always started with a definition, and so I'm referring back to the original title of the talk where the word recidivism was used. This is a noun that should not be used with regards to weight regain. It's the tendency of a convicted criminal to reoffend, and has nothing to do with our patients, so we need to drop the word recidivism. So I was a little surprised when I saw it in the title that was sent to me, because definitions and nomenclature matter. And I'm going to explain why in a second. This is the ASMBS study looking at terminology. It's the Power paper, Post-Operative Weight Recurrence Task Force. It was a meta-analysis looking at 400 articles with 25 definitions. And the conclusion was the adoption of oncological terminology for what we do. More descriptive terms: primary responder, primary non-responder, suboptimal weight loss, secondary non-responder, and recurrent weight regain. And the reason this is important and relevant to my talk is reviews like this that come out now. Systematic reviews, non-randomised, controlled papers looking at revisional bariatric surgery after sleeve gastrectomy. And the conclusion was that due to the data heterogeneity, the prospective nature of the trial, the non-randomized nature of the trials, the retrospective nature of the trials, but mainly the use of definitions and the difficulty then in determining outcome and then subsequent bias means that we don't have an answer regarding revisional surgery after sleeve gastrectomy. This is a common issue with bariatric surgery where we know we're doing the right thing, but because we haven't defined what it is that we're doing, we're struggling to prove it. So this is the first sentence here is what you've been seeing throughout this Congress over the last couple of days. Obesity is a chronic, relapsing and multifactorial disease that requires long-term management after primary metabolic and bariatric surgery. The second sentence is what I'm going to try to prove, and at the end of the talk I also explain where this statement comes from. So we need to look at it as a chronic disease. We see it in other areas of surgery, orthopedic surgery, ventral hernia surgery, surgical oncology and cardiac surgery. Why we must assume that it has applicability to metabolic and bariatric surgery. We should be having textbooks on revisional bariatric surgery. We should have journals on them as well. And I often like to refer to this, the original paper. We need to know where we come from. This is the original paper looking at the sleeve gastrectomy as a two-stage process in the super obese, yes. But we reap with what we sow. Why do we now fear the burden of revisional surgery? This is what it was intended for. I view it as a good thing that the sleeve gastrectomy allows me to do a second operation if needed. So I have to go through some of the evidence for surgery after a sleeve with rate regain. This is from Tel Aviv, this study, Roux-en-Y gastric bypass, 23 patients. The average BMI decreased 42 to 33, 50% comorbidity resolution, the mean follow-up 2 years. This paper is from Ralph Pedderly's group in Basel, Switzerland, and thanks to Ralph, he presented this on Tuesday. 549 patients, 9-year follow-up, 3 different operations, the BPD-DS, the short BPL length gastric bypass and the long BPL limb gastric bypass, 60-month follow-up after the revisional operation, so good 5-year data after the revision, and excellent excess weight loss results. We've been here before, we've reviewed this before. The ASMBS did a huge review in 2014. Yes, it was many years ago. John Morton's name is on that, Jaime Ponce, Stacey Bredhauer is the first author. It was not so early that it didn't include sleeve gastrectomy conversions or revisions. 175 articles were reviewed and analysed, a single centre retrospective data, of course. And the conclusion was favourable outcomes after reoperative procedures with additional weight loss and comorbidity reduction. And the statement at the end of the paper is one I particularly like. 1 bariatric procedure per lifetime and other coverage policies that limit or prohibit reoperative bariatric surgery are not consistent with coverage policies provided for any other chronic disease process, and they should be abandoned where they exist. Why do we apply it to bariatric surgery? This is a more recent review, meta-analysis, specifically looking at sleeve to bypass, 2023, 44 relevant studies, over 1,500 patients. The redo surgery was laparoscopic Roux-en-Y gastric bypass, 55% excess weight loss or a further 7-point drop in BMI, and a 53% diabetes remission from those that recurred after their original operation with a very acceptable perioperative complication rate. This is a recent paper, recent meta-analysis. This paper from Germany, from Rudi Weiner's group, 55 patients, lap gastric Roux-en-Y and 1 anastomosis, 12-month follow-up, again, acceptable post-operative complications, excellent percentage excess weight loss for both groups. This paper from Ido Arts group in the Netherlands, SADS's and Roux-en-Y's, mean 5-year follow-up from the reoperation, 141 patients, tremendous total, very acceptable percentage total weight loss for the SADS in particular. So that statement that I gave at the beginning is from your society, IFSO. In the most recently published 2022 ASMBS and IFSO indications for metabolic and bariatric surgery, there is a statement at the end regarding revisional surgery. Severe obesity is a chronic disease, needs long-term management after primary metabolic bariatric surgery, and this should include the potential for revisional surgery, as well as, of course, other adjuvant therapy. And I'm just going to finish. On Tuesday, we had a postgraduate course on revisional surgery. And we were lucky enough to have Dr. Lee Kaplan speaking in that session. For those of you who don't know, Dr. Kaplan is the Director of Obesity, Nutrition and Metabolic Institute at the Massachusetts General Hospital, and his life's work focuses around molecular mechanisms and physiology of gastrointestinal regulation of energy and metabolism, and he's developed a number of different animal models looking at bariatric surgery, and his expertise extends into the use of adjuvant therapy, of course. And I went to the talk that he was giving in this session, which was on MBS mechanisms of actions, how do our operations work, the role of adjuvant medical therapy. And I went to the talk expecting to be told that we'll never do another revisional operation again with all the adjuvant therapy that's come through. And this was not the case. Lee has given me permission to quote him in saying it's a different mechanism of action. There is certainly a role for revisional surgery in the setting of recurrent weight regain. Thank you.
Thank you, Jacob. Please come and sit up here with us. I'll now invite David Sauer to tell us that lifestyle modification can be preventative for recurrent weight gain. Thank you, David.
Thank you, Dr. Cow, and the moderators for inviting me. I'm actually thrilled that you have asked a non-surgeon to comment on these issues. I'm actually a psychologist by training, and have had the great pleasure of doing a great deal of work in this space for the last 20 to 25 years. So like Dr. Chisholm, I modified my title a little bit. So I guess both the Aussie and the American cheated a little bit when it came to their assignments for this. But I think what you're going to see is that we end up in largely the same place. This paper just came out a few months ago, so some of you may not have seen it yet. And what it actually talks about is the fact that inadequate weight loss or weight regain are common reasons for conversion to a secondary procedure. And this is actually a focus of a great deal of my work right now, where obviously we know bariatric surgery is an incredibly powerful tool. Regardless of which interventions we're providing to our patients, it's far superior than pharmacotherapy or behavioral modification. But many of our patients, that 20 to 30%, are really challenged to maintain those early weight losses the further they get out from the time of surgery. And as somebody who falls on the behavioral and the environmental side of the street, this is actually something that's very concerning to me, because we can talk about the physiology and the genetics that play a role in the development of obesity, but I think it's always important that we remind ourselves that we return our patients back largely to the same environment that contributed to the development of severe obesity in the first place. And so while I could probably spend a half an hour talking about environmental engineering and prevention efforts, we need to keep that in mind as clinicians and providers, that our patients, while maybe better suited for those environments, still face some of those environmental and behavioral challenges. So over 10 years ago, with some other colleagues in the United States, we wrote a review paper, I believe this was published in SWORD, that talked about what are the reasons that we think about weight regain. So we can talk about physiological adaptation and hormonal changes over time, but we also know that things like preoperative psychopathology, namely things like binge eating disorder, play a role in postoperative weight regain, disordered eating, as well as poor adherence to the postoperative diet and behavioral recommendations that we give patients prior to surgery. So regardless of whether meeting with a mental health professional or a dietitian is required in your country of origin, we know that patients who are challenged to understand and implement that education, that preoperative education that we give to them, often have less good successes. So what can we do? What can we encourage patients to do behaviorally after surgery to be successful? Well, we can encourage them to self-monitor their weight, their dietary intake, and their eating behavior. That's something as simple as encouraging them to get on a scale once a week, record their weight, and keep track of it can help them maintain their weight loss over time. Many of the other presentations we've seen today, including an entire session in the integrative health section, talked about the role of physical activity. And how do we come up with creative and novel ways to encourage people to increase their physical activity, decrease their sedentary behavior, if in fact prior to surgery they were incredibly sedentary because of the severity of their obesity and the comorbidities that come along with it. And it's a tremendous challenge, as we all know. How can we maintain patient-provider contact? And we wrote this pre-pandemic, before things like telehealth and text messages with patients were as commonplace as they are today. So I think we've actually entered a new era in healthcare where maintaining long-term contact through electronic portals is a really useful strategy to promote long-term success. And then obviously we have direct intervention, whether it's intensive lifestyle modification, time-restricted eating, or something called acceptance-based therapy that I'm going to talk about in just a moment. Now, we know that lifestyle modification interventions are the cornerstone of weight loss treatments, and they really involve three main pillars. So there's caloric restriction, which is asking patients to restrict their calories by approximately 500 a day. There's increasing their physical activity up to approximately 180 minutes per day. And then there's behavioral modification strategies. And the main strategy there is self-monitoring. So encouraging patients to weigh themselves, track their calories, track their physical activity, have them become experts in their own behavior, and then be able to change and tweak their behaviors on the fly when something happens. So if somebody goes to the gala tonight and overeats at the Opera House, they get up tomorrow and maybe they add an additional half mile to their run to compensate for the additional calories that they had this evening. Now, the good news is that numerous major efficacy studies done in the United States and throughout the world, things like the Diabetes Prevention Program and Look Ahead namely, have shown that individuals can lose approximately 7 to 10% of their body weight by using these strategies and adhering to them for about 6 to 12 months. And that these losses, while far more modest than what we see with bariatric surgery, are associated with significant improvements in weight-related comorbidities. And for these reasons, approximately 10 years ago, the American Heart Association, along with the Obesity Society, which is the major non-surgical obesity organization in the United States, now consider a 5% weight loss to be the first goal of a non-surgical, non-pharmacological treatment. So if we can get patients to lose 5% of their weight, they're on the way to success in improving their health. Now, the promising news is that these interventions can now be delivered effectively in primary care, and there's a growing evidence base that physicians and other providers in specialty practices, such as oncology and reproductive medicine, can also learn how to deliver these interventions to patients, and that now a new generation of interventions, even prior to the pandemic, has shown that we can deliver these interventions by web portals, text messaging, and telehealth visits as well. But here is the bad news when it comes to lifestyle modification. Those e-health, m-health interventions that are become more and more common seem to be less effective than in-person visits. We all know the power that can come from an in-person visit with a patient. We've all experienced it. We can all think about those anecdotes where a patient cries and gets upset and you comfort them. Or they say, you know, I got a lot out of that support group, or your dietitian is wonderful. Our patients can tell us that there are people in our practices, providers in our practices, who have been key to their long-term success. So there's great power in that one-on-one interaction that seems to get lost in the technology. Unfortunately, regardless of how you deliver these interventions, 1/3 of patients regain weight within 1 year, and almost everybody regains it within 5 years. And I have a slide, and I don't have it here, where I show the typical weight regain from lifestyle modification interventions in response, in contrast to the 20-year results from the SOS trial. You see how pale in comparison lifestyle modification is. It's barely a drop of water in that ocean of success that we see with bariatric surgery. And so these results really underscore the importance of seeing obesity and severe obesity as a chronic disease that requires a long ongoing treatment. Now, a number of investigators have said, well, what if we take those lifestyle modification interventions and we apply them to bariatric surgery? Can we get the same results? And unfortunately, as you see with this last bullet point here, the answer seems to be no. That a meta-analysis done about 10 years ago suggests that there's actually minimal differences between people who get a post-operative lifestyle modification intervention and those who do not. And what I would add to this is simply the following. Most of our patients who present for bariatric surgery are what I like to call dieting veterans. they've done this before, and they've done this before numerous times. So asking them to go back and engage in lifestyle modification may not be the most appropriate strategy. Yet, before we throw the baby out with the bathwater, consider this study by Jim Mitchell in the United States, which comes from the Labs Consortium from several years ago. Jim looked at 25 distinct behaviors that patients engage in after bariatric surgery. And what he found is that 3 behaviors of those 25, patients who weigh themselves weekly, stop eating when they're full, and stop eating continuously throughout the day, who stop grazing on food, if you will, are more successful in maintaining their weight losses than patients who do not practice those behaviors. So if you're looking for a clinical pearl in my talk, this may be it. So whether it's the dietitians, the mental health professionals, the surgeons, the nurses, if somebody can encourage patients postoperatively to change these 3 modest behaviors, maybe that's part of the recipe of success. But let me end with the following. There's a new generation of cognitive behavioral therapy that has started to emerge within the last 10 years called acceptance and commitment therapy. And it's really based on the notion that when we encounter uncomfortable experiences, like anxiety or tempting foods, we oftentimes engage in behavior that run counter to our values. We're trying to lose weight, but we're at the opera tonight. There's this tremendous spread of food. There's fantastic desserts. Somebody is saying, I'm trying to control my weight. I'm trying not to try that cannoli, but everybody's saying how wonderful it is, so I give into the craving, and I end up having the cannoli. So how can that patient recover from that moment? And part of it is to realize that those challenges are going to come, to face the uncomfortableness, and to move forward from there. And a number of small studies have actually suggesting that these interventions can actually be quite effective. One of my colleagues, who's now at Rush University in Chicago, Dr. Lauren Bradley, did a pilot study several years ago. I believe this was also published in SWORD, where she took 8 individuals who had regained at least 10% of their weight and gave them a 10-week acceptance and commitment-based therapeutic intervention delivered in a group-based format. She's now modifying it for an online format. Look at the weight losses that she saw in 10 weeks. All 8 patients stopped regaining weight, and some of them, as you can see, actually lost up to 7 to 8% of their weight in that 8-week intervention. So maybe delivering some of those interventions are the key to success. So it may be that traditional lifestyle modifications, things that our patients have done over and over again, isn't really the path to long-term success, and that maybe it's these acceptance-based approaches, which is a more novel and engaging approach, may be more helpful to patients over time. But with all of that being said, I would say before we take a patient to the operating room for a revision procedure, it's critically important that we evaluate the psychosocial, behavioral, and dietary issues of our patients. If one of my surgeon colleagues comes to me and says, David, they have a medical complication and you still want me to do something behavioral with them, well, of course I'm going to concede that point. But in the absence of a medical or surgical explanation for the weight regain, I'm going to hedge my bets that it's a behavioral or dietary issue, and maybe there is something we can do for these patients before we take them back to the operating room. Thank you all very much.
Thank you, David, for convincing argument. Jacob, what do you have to say?
Thanks, Lillian, and thanks, David, for your talk. My rebuttal really is about, well, show me the data. You talk about lifestyle-based approach may show a difference. You talk about acceptance-based approach may prove a difference. I've had to get up there and present multiple different papers over many years, follow-up, proving the results of bariatric surgery. Why should we be submitted to the same rigors of evidence-based medicine and not other interventions? And so that's my rebuttal.
Well, I think that's actually a very fair point. I do think the evidence base in this area is still small and developing. I do worry, and as you probably gleaned, I still am a pro-surgery guy. Yeah. So this isn't an either or, let's do lifestyle modification and not surgery. Again, I worry more about that 20 to 30% of patients who do not respond well to the initial procedure, and what do we do with them? And it's one of the reasons I made the comment to Dr. Cow that I was thrilled that you have a non-surgeon representing the other side of the street here. You know, in the absence of compelling evidence that there's a behavioral or psychosocial issue that's driving this, I would concede the point that taking somebody back to the operating room makes sense, or converting somebody from a sleeve to a bypass makes sense. I'm thrilled that you brought the history of that back up, because that history was about the time that I was entering the field, and I'm kind of amazed at where we are today that sleeve has gone to the primary procedure that it is. But I do think that when we consider that the average age of our patients is typically in their early 40s, that means 30 to 40 years that we're working against to try to promote long-term success. And whether it's a secondary procedure and or lifestyle modification, I'll go back to that point about the environment. They're still in that environment that contributed to weight gain and the challenge of weight maintenance that we all face.
Thank you. Amino, what do you think? Lifestyle change,
Yeah.
reoperate.
Not easy, yeah? But in Brazil, we work based in insurance companies that are paying for the procedure if the patient have recommendation for doing that. And we have different recommendations coming from the insurance. So we have some insurance that allow us to prepare the patient and operate. That will take 2 or 3 months. We have insurance that are recommending 6 months preparation, 1 year preparation, and up to 2 years preparation. So we have different groups of patients to analyze the result in the postoperative of these patients. And honestly, I cannot see that patients that they did 2 years preparation for the procedure, they are the best patients in terms of success about weight loss and control of associated disease after the surgery. So again, we have very good points here from Dr. Jacob and Dr. David, but I continue without a clear way about thinking about this situation. But any also relapse or recurrence of weight after bariatric surgery, I think that we have to stop, to talk with the patient, to put this patient in a very close multidisciplinary preparation for the surgery. We used to do this for at least 6 months in considering revision of surgery, and to decide about the procedure. We could see here very good data presented by Dr. Jacob that maybe Roux-en-Y gastric bypass, it's not the best alternative for these patients, because he showed us loss of 8 points of BMI, 7 points of BMI, and we have much better result with SADIs or duodenal suite. So again, I think that we don't have a general rule for that. Will depend, we have to take patient by patient.
Thank you, Amino. Looks like you haven't got a clear pathway. I see someone down there. Sorry, I can't see you because of the light.
Thank you. My name is Jorge Huaco from Massachusetts. I'm a surgeon, and then I'm okay with reduced surgery. But my question is, what if you do a second surgery and the patient regains the weight? Are we going to offer a third surgery? So let's say we do a sleeve gastrectomy in a very young patient, like in the 20s, 30s, and we see this patient in the 40s with the same BMI that the patient had before. Let's say we do a bypass or a SADIS, and the patient 20 years later, now in the late 50s, regains weight. What are we doing at that point? Are we doing a third surgery? Are we advocating for a third surgery?
Because it's a chronic disease.
Yes. So all right, thank you very much. Thank you, David. Thank you, Jacob. We'll now go back to the first debate, I'm going to invite Dr. Khalid Gaudet to give the fact that sleeve gastrectomy is doomed to fail as a standalone procedure.
Are we ready? Can we have the first set of slides, please? Okay. So, of course, I had a big smile on my face when I was given this debate. Unfortunately, I'm debating against Sylvia, but we'll see. So, I don't have any disclosures. This is my case mix disclosure. I do very few sleeves. Now you're getting why I'm doing this. And 70% of my work is revisions. And every procedure I do, it's a banded procedure. So even when I do a sleeve, it's a banded sleeve, banded bypass. You know, if you want to tell people the truth, you have to make them laugh, otherwise they will kill you. Every surgeon likes the before and after pictures. So this is a nice before and after pictures. So in 2 weeks, Johnny lost 2 weeks. So if you do it for sleeve, post-sleeve, same picture. In 5 years, Johnny lost 5 years. This is what's happening now. And you know, a lie often told becomes truth. And the trouble with many of us is that we would rather be ruined by praise than saved by criticism. For me, everything started here in Napoli, in Naples, with Luigi Angiusani in 1999. This was the first bariatric surgery conference I attended. And of course, it was Luigi and Nicola, the great Nicola Scopanaro. And this was the time of the laparoscopic explosion, where we were transforming surgery from open surgery to laparoscopy. Bands and bypass started in 1993, OHGB in 1998. And in 1999, Michel Gagné performed laparoscopic duodenal switch. And that was something huge at that time. And that also was the start of the lap band era. So this was advertised as the easy, reversible, no cutting, no stapling, adjustable, laparoscopic, no supplementation, and good weight loss. We were sold into this. And you know, the gold standard of any scientific study is whether it could be replicated. So I sit in a conference, I hear that, I go home, I do it, and it doesn't work. So in 1999, I performed 44 lap bands, and these are the 44 sins of my life. And this started a new concept for bariatric surgery, the perfect deception. This was the birth of the commercial bariatric surgery. So, you know, you have an easy procedure that has short-term success, and on the long term, who cares? And if the patient fails, just blame it on the patient. And the demise of the lap band, unfortunately, did not happen because surgeons proved by science it's a bad operation. The demise happened because patients knew from their peers it's a bad operation and stopped asking for it. Otherwise, we would have been still seeing thousands and thousands of lap band cases. And the same thing is starting to happen with sleeve gastrectomy. Now it's not infrequent that you see a patient and he would tell you, well, I have friends that had the sleeve gastrectomy and it doesn't work. You know, also with the honeymoon phenomena, all bariatric procedures will give you some weight loss in the first 18 months. And all bariatric procedures will show you some weight regain after that. And your results at 5 to 10 years will be completely different from your initial results. And this was proven by many studies, as we all know. Also, the honeymooner dilutional effect. Michel Suter taught me this. If you, for example, if you're a surgeon doing 100 cases in the first year, 200 cases in the third year, in the second year, 300 cases in the third year. By the end of the third year, you have 600 cases in your series, and you're projecting that you have 85% success because you have only 100 patients that failed. That could be your first 100 patients. So if you stop adding new cases to your series for calculation, you can have a better grip on your results. So, you know, sleeve gastrectomy is the #1 operation worldwide. But, you know, the voice of majority is no proof for justice. And sleeve gastrectomy is doomed, yes. Why? Because of weight loss failure and gastroesophageal reflux. And, you know, let's get back to the history. Many of you weren't there when that history started. Why was sleeve gastrectomy a standalone procedure? Because the laparoscopic duodenal switch by Michel Gagné and the super obese produced very high complication and mortality rates. He had 10% mortality for the super obese patients. So he said, well, let's do it on stages. So we'll have the first stage, bring the patient back 6 months to a year and do the second stage. But what happened is that patients did not come for the second stage because they were still in their honeymoon. And this was still working for them then, and they never showed. So that's okay. Let's keep it and as a standalone procedure, and we call this serendipity. And you know, the demise of the lap band pushed the rise of the easy does it sleeve gastrectomy. So, you know, with confirmation bias, it's a natural tendency to accept evidence that confirms what we already know, and to accept facts that only strengthen our preferred explanation and dismiss data that challenge what we already accept as truth. And we all have the inherent and natural tendency to search for evidence that already meshes with our beliefs. And it's a nature of confirmation bias itself to dismiss all contradictory evidence as irrelevant. So my evidence is always the rule, your evidence is always a mistake or an exception. So I don't like sleeves. Any bad publication about sleeve, I keep. Any good publication about sleeve, I erase. Everyone believes they are the good guys, and those who differ are the bad ones. And no one on the bad guy's side feels they are doing anything wrong. And it is not hard to do the right thing, it's just hard to know what the right thing is. So, have you ever seen the commercial sleeve-only surgeons trying to convince patients with sleeve gastrectomy? So this is what we see. Oh, come on, sleeve is the best weight loss option. Simple, easy, effective, and physiologic. And you know, you don't need vitamins. No worries about reflux, and gives you permanent weight loss. So sleeve is as good as Roux-en-Y gastric bypass? Yes. Which Roux-en-Y gastric bypass? If you have a big pouch, Roux-en-Y gastric bypass, big stoma, any operation would be better than that. Every stomach will stretch with time. A wide sleeve, it's fashionable now to have a relaxed sleeve. This will have a comfortable patient and dilate quicker, and narrow sleeves are more uncomfortable and take longer to dilate. Sleeve gastrectomy is the only self-reversing bariatric procedure. Just give it enough time that it will dilate. And now we come to rationalized failure. So weight loss is not important, even though it's a weight loss operation. So comorbidity improvement is enough, and it works through hormones and other mechanisms. And I did my part. The patient did not change. So nice. Logic-defying science is wrong. And by the time the inevitable long-term failures appear, we will have millions of failures. So the true definition of sleeve gastrectomy, it's an irreversible, reflux-inducing, radical gastric resection that gives temporary gastric restriction. Every stomach will stretch. If you see the competitive eaters, when they eat 100 sandwiches, they just make their stomach as big as their abdomen. This is interesting. This is from the IFSO website. Disadvantages of sleeve gastrectomy surgery: potential higher inadequate weight loss or weight regain, irreversible, considered investigational, considered temporary treatment for obesity unless a second stage is performed, potential for dilatation and sleeve of the sleeve affecting weight loss. Also, the reflux issue. It's a reflux-inducing operation, and this is undeniable. So if you hear people doing reflux patients, give them sleeve, I don't think it's right. There are so many mechanisms with that, and there is a lot of literature to support that. Also, the Barrett's matter that was fashionable a few years back, with 15 to 18% Barrett's after 5 years for sleeve. And there are also studies, if you fix it, if you fix the hiatus It doesn't affect the Barrett's numbers. They still have Barrett's. And the greatest of mankind criminals are those who delude themselves into thinking they have done the right thing. I've attended the duodenal switch group meetings at the ASMBS, it was called ASBS then, and every year they do the procedure differently. So Hess would measure the rule of thirds and Morceau would do 100 centimeters. And Balthasar would just every year change the bougie size, the sleeve size. So I did duodenal switches and they fail. So ego is the anesthesia that deadens the pain of stupidity. So the problems with what we do nowadays is that it takes you 5 to 10 years to know what you're doing now, dilutional effect of honeymooners and also the non-standard reporting. And why procedures fail? Well, first and foremost, obesity is not a GIT problem. And all pouches will stretch and dilate. Small bowel will adapt, hyperplasia and hypertrophy, and dumping will resolve, and hormonal changes will go back, and food intolerance will improve, and the social and behavioral changes remain. So, you know, the aim of argument should not be victory, it should be progress. And if you want the present to be different from the past, you have to study the past. And be a free thinker, don't accept everything you hear as truth, be critical and evaluate what you believe in. Facts do not cease to exist because they are ignored. And the truth will set you free, but first it will piss you off. Alfred Kosheri says there are patients whom we cannot help, but there are none whom we cannot harm. So in conclusion, sleeve gastrectomy is doomed. Sleeve patients should come back for second stage after the honeymoon, and weight loss failure and reflux will cause the demise of the procedure. Logic-defying science is wrong. I'd like to invite you to our conference in Egypt, ASBS, in next October, and thank you very much.
Thank you, Khalid, for being so convincing. I'm now going to invite Sylvia Weiner to prove Khalid wrong.
It will be my pleasure. We are in a special situation because I think I don't need a lot of pictures to convince you, not a lot of maybe flat arguments. I mean, we are a little bit in the debate, so we're a little bit fighting each other. So I will do like a little bit stand-up thing, and I want to start with one question. I mean, how many obese patients do we have on the world everywhere? It's millions. Honestly, do we really believe that they all have the same disease? No, I don't. I don't think that obesity is one disease. I think there are several diseases, and I say, and we have enough proof for that, Rachel Betterham was working a lot of that, a lot of colleagues, this is a metabolic disease. It has nothing to do with eating or exercising. You all know these people who can eat whatever they want, or they're exercising or not exercising, and still we try to cure all these patients with 1 or 2 procedures, and we are still talking about diets, and sorry, David, where are you? We are still talking about behavior. Maybe for some it's the behavioral issue, true, and we need to find out in before. And maybe with some it's the diet. But we know that the brain is sitting on his gold, which is sugar. And we know about the fat giving out all the hormones to make us being hungry. No one is just eating because he wants to be fat, and we have to consider that. I mean, of course, there are maybe some for other psychological reasons, and of course, we're not operating on them, but people don't want to be that. Obesity is not a choice. It's a disease, and maybe we have many diseases. And it's also not about limb lengths and all these things. And I have been with Michel when he started doing the sleeves, so I feel like getting old right now. So what did we do? I mean, we have been discussing for years and years about limb lengths, back and forth, circular anastomosis, back and forth, the size of the sleeves, resecting the fundus, yes or no, and what do we get? We get all different results. We don't have long-term results. Why? Because maybe we lose these patients to follow-up because they are good. They are doing a normal life. They have a disease which we don't understand till, and we treat them, and of course they go their way. I'm not a big sleeve defender normally, but I tell you what, men are not successful in the most areas of life, but with the sleeve, men have very good results, better than women. Normally it's other way around in life, but with sleeve in men, the number of reflux, of weight regain is less. And we know very good data that if you look at big numbers, you don't see a difference between the procedures. And if we look on small numbers like 53 cases of reflux after sleeve, my God, we are choosing thousands and thousands of cases worldwide. So it's about the choice, the patient, what we choose for the surgery, what we do on prehabilitation. It's like educating them, telling them what's going to happen, but we must not expect that, you know, if the disease can be treated by a dietitian and behavioral, we all would not be here, we would do cancer surgery. So I think sleeve is a very good option for men, for people who are educated in before, and they don't, I mean, men, honestly, they don't want to type in the app every day what you're eating and not eating, or you don't want it. I don't want it as well. So some people just go on like that. They need to know in before, and they have good results, and of course, we don't see them back. We don't see them back in our studies. We don't see them back in our outpatient departments, and they go well. And we have a very good stage to see if this modulation of our hormones, of the vagus nerve, might help enough. And in some patients, we might need the modulation of the incretins as well with adjusting the procedure even more. So if we have a disease, I tell you, we have a disease or maybe many diseases, and like with hypertension, we start maybe with one procedure. We start with hypertension with one pill. And if it's enough, and we treat the patient fine, we are happy. So why not doing the sleeve and see if the patient is okay? So, and if the medication for the hypertension is not high enough, then we go for a second tablet. Why not give them a second pill? So why not giving a second surgery to them? If we accept obesity as a disease, maybe many diseases, even if we don't understand what's happening. So therefore, there will be many sleeves in the next couple of years. Of course, there will be many revisions. That's true, but that's the best what we can do. And we need to make sure that we educate well our fellows, that they do the procedure properly. Because what we see for sleeve failure, like dilated fundus or other things, that was primary surgical failure. And we must be aware that we just do what we can, doing proper surgery, making good choice of the patient, and doing a good prehabilitation, and just accept them with their disease and not blame the patient.
Thank you, Sylvia. It is only Sylvia Weiner that can do this debate without any slides. So Khalid, what have you got to say?
Oh, well, I enjoyed very much the way you treated men. So, so if men are successful, why would you offer them inferior treatment? That doesn't make any sense. You can still give them a better operation. And, you know, if it's going to dilate and they're going to fail later. This is the whole point. It's a good operation. It's a good first step operation. But it's never going to work as a standalone operation forever. And also, obesity is a disease. Yes, it's a disease, and this is one of the tools, but there are better tools out there. And the reflux, you said that there are 55 cases in one series. It's 50%.
But you have
the
like
long-term reflux after sleeve is 50% of the patients.
You can also heal. It's like 30% get better, 30% get de novo reflux, and 30% stay like they are, like they have been before.
Yeah, so that's painful. So why would you give them an operation that would give them 50% failure and 50% reflux if there is options that would have better outcomes.
Yeah, it's 60% success, it's only 30% reflux.
Okay.
So the glass is always half full instead of half empty.
Okay.
Almino, what do you say?
Yeah, honestly, Lillian, I hope, based that we have right now over the world, about 60% of the surgeries, they are sleeve gastrectomy. In the United States, much more. I really hope that my good Egyptian friend here, Khaled, would be 100% wrong about his opinion, unless we will have terrible problems over the future with this kind of patients. But I think we cannot be so pessimist as Khaled or so optimist as Sylvia. We have to think about data. So in this Congress, I have the chance to see at least 3 sessions with comparisons in 5 or 10 years in Roux-en-Y, gastric bypass and sleeve gastrectomy. And the conclusion is that the weight loss is not so different, Khaled. We are talking about, in terms of percent, 5 to 7% about the total weight loss when we see both group of these patients in the long range. But the group of sleeve gastrectomy will have 30 to 40% revisional rate, mainly regarding sleeve. So in my point of view, and that's what we are done in Brazil right now, in our clinic, we are doing about 60% of Roux-en-Y gastric bypass, 25 of sleeve, and the rest it is endoscopic procedures, duodenal switch, SADIS, and OAGB. That we can have good patients for sleeve gastrectomy. What is a good patient for sleeve gastrectomy on my mind? Mild obesity, let's say 40, 42 maximum BMI, no reflux, no hiatal hernia, no severe metabolic disease, and with this kind of patient, I think we can have a good result over time. And I remember some specific situations because when I am in my office, I can check the data of the patient before the consultation. And when I check the BMI and the weight loss, sometimes I think, wow, that's too bad. And when the patient comes to the consultation, the patient are very, very happy with the result. So we have to balance because it's not all just about weight loss, because the quality of life of the patient, I think it is the most important way of evaluate result of bariatric surgery. Other patients, they are with a fantastic result, and when the patient comes to the consultation, you say, well, okay, good, congratulations, you are doing good diet, you're doing exercise, and the patient just say, come on, doctor, I'm not doing nothing. I'm just having the result of the surgery. But again, I hope that the vision, the pessimistic vision of Khaled will not be the true for all of these patients over the future, because the world is doing a lot of sleeve gastrectomy. Thank you very much, Lilia.
Thank you.
Thank you, Almino. I'd just like to say that today's session was just to give you 2 sides of a story of various aspects of sleeve gastrectomy. It's a debate, so we've had the good side, the bad side, the optimists and the pessimists, but hopefully at the end of the session, you get a balanced view of how you can twist the story to convince someone. But we are surgeons, we are here to treat a disease, and we do the best for our patient. So I'd like you to join me in thanking all our debaters for providing their side of the story, And thank you to Omino for helping me moderate.
I would say, Lilian, that we can have the pessimist vision, the optimist vision, and the real true, the true of Khaled.
I'll see you in 10 years. I'll see you all in 10 years.
Well, thank you very much, everyone, for participating as well and for being in the audience. Thanks again. I'll close this session now so that we can get to our next, whatever we're doing tonight.
Sleep.
Hey, Sylvia.
There are places that you go to and once is enough. And then there's Napoli. There are places that you go to and once is enough. And then there's Napoli.